Okay, welcome to the AMSER Intro to Women's Imaging YouTube video. My name is Matt Hartman from Pittsburgh, PA.
And I'm Dominique. I'm a fourth-year medical student from Drexel. And today we're going to be talking about a couple different resources for people going into ObGyn, whether you're a medical student, rising intern, anything like that. These are things that I have discovered on my rotation here with Dr. Hartman and have been really useful, and I wish I had known about them sooner. So this is the ACR Building Blocks. You can find it on the ACR website, and it's free. The content is free to all medical students. You just have to sign up, and it has access to a bunch of different learning resources, including PowerPoints that you can go through. It touches on a bunch of OB topics, GYN topics, both radiology related and anatomy and just different disease processes in ObGyn. And you can also watch some YouTube videos that kind of go through the PowerPoints, but if you want more detailed information, you can go through those at your own pace. And there's Anki cards also for the different material.
So this is the RadPath channel we created for the pathology section of the building blocks. And we have, I believe, 15 videos covering all the major organs, including GYN. We'll have a uterus, ovary, and we also have a crash course for how to read a pelvic MRI, which I did with another student. And we have Anki decks, as mentioned, for the RadPath material. So a little bit about me. I'm a body imager. I love RadPath. I love women's imaging. And all that material is there for students who want to learn more about ObGyn. This is perfect if you're a third-year student about to start your clerkship, or you are going to be a future intern going into ObGyn. And it's over 100 slides. I'm going to sort of give you an overview of what's available, but a lot of anatomy, a lot of vocab, talking the talk, some key concepts, and then some interactive cases. I'm going to try to throw some pearls out as we go. So some exquisite anatomy in this material. Here are the uterus and the ovaries on ultrasound. More detailed of the ovary with a couple of follicles. A lot about first trimesters, so some fetal anatomy. I'll give you guys some pearls coming up. The uterus with the endometrial stripe. What's normal, what's abnormal. These slides will cover that. And then some pathologies like endometriosis. So where does it like to occur and what does it look like? Again, if you watch, you might be looking at this, a pelvic MRI, that's pretty overwhelming. But if you read watch the video about how to read a pelvic MRI, the crash course, we'll give you some pearls and get more comfortable with that. But here's a big endometrioma. Cervical length. So now getting into OB, I was told by one of my Drexel students that this question in particular, this slide in particular helped for answering one of the questions on the shelf exam. And we, Dominica and I had a case of this the other day. We had cervical length of 40 millimeters, so we knew this was normal. You want it to be 30 millimeters or more. So that is a good OB pearl. Ectopic pregnancy. So again, going into some first trimester pathologies, always worried about this. We do a great job in the slides covering this topic. Going to the third trimester, second and third trimester, talking about placental pathologies. So the very adherent placenta, the accreta, increta, percreta. What's involved with that? What does the MR imaging look like? It's a great way to diagnose it. Here you see the placenta going through the wall. So this is invading through the myometrium. This was a percreta, and the risk factor is multiple C-sections like this patient. Abruption, painful bleeding during the third trimester. And we have a nice diagram there. Here's our placenta, and there is an echogenic collection behind that, retroplacental hematoma. The differentials for pregnancy, oligohydramnios, polyhydramnios, these are things we cover. Whenever I see oligohydramnios, I think of a renal problem in the little baby. Pathologies such as tubo-ovarian abscess, and what does it look like on MRI? Now, here are some Hartman pearls. You will not find these in the actual slide presentations, but it's sort of a summary of a lot of those key concepts. So something called the discriminatory zone. I find this extremely helpful. It is the beta HCG level at which you expect to see something on ultrasound if you have a pregnant patient. And that level is typically 1500 if you're doing a transvaginal ultrasound. And then also knowing what is our differential if you have a patient first trimester with bleeding. It could just be a normal implantation bleed, could be an ectopic, could be a molar pregnancy with a snowstorm appearance, or you could have a fetal demise. And the presentations will go through all of these. I wanted to throw this out there, the normal ultrasound progression, what we expect to see when you have that discriminatory zone of 1500. The first thing you'll see is a intrauterine gestational sac, hopefully. Then the yolk sac develops, and then the embryo with a heart rate. And some useful numbers, which I find helpful in my daily practice. Once we have that gestational sac, the mean sac diameter, if it's greater than 10, you better have a yolk sac. If it's greater than 20, you better have a yolk sac in the embryo. Once we have the embryo, if it's 7 millimeters, you better have a heart rate. Now, if you have an embryo that's 4 millimeters, no heart rate, I'm gonna tell you, normally we'll see a heart rate if it's 3 or 4 millimeters, but if we're not seeing it at that point, we give the mom and the baby the benefit of the doubt, and we say, wait 10 days, and we'll see if there's a heart rate at that point. This case just came up today. Postmenopausal female with bleeding. We're thinking about endometrial cancer. This is a great number to know. If the endometrial stripe is greater than 4 millimeters, here on the ultrasound, it was 1 centimeter. And on the CT, a couple of months had passed, and it's gone up to 3 centimeters. So this was a advanced endometrial cancer. We recommend biopsy. This indeed was endometrial cancer, but remembering that number, 4 millimeters. Some general information, which is helpful to whatever specialty you're going into. You might have seen someone changing the windows when they're going through a CT scan. All that means is they're changing the grayscale. Here we see the lung detail. This is more of a soft tissue window, and this is a bone window. For this, we have to understand what Hounsfield units are. I think every intern should understand what Hounsfield units are. It's a measure of CT density. Water is 0, air is negative 1,000, bone is a positive 1,000. Fat, such as in the teratoma, will be about negative 50, and blood, if you have hemoperitoneum, you'll be measuring about 25 to 30. Our modules also have tons of interactive cases, topics like PID, infertility, ectopic pregnancies, and GYN malignancies. And I will turn it over to Dominique, who did a great RadPath case with us this month.
Yeah, so I can go through my RadPath case really quickly. This was a patient that I had the chance to follow through kind of her workup of this mass that they found on imaging for her, and kind of got to see the radiology side, the pathology side, and then seeing her through surgery and what that all looked like. So this was a 55-year-old perimenopausal female. She presented with abdominal pelvic pain, and she actually went to the emergency department for this. She noted that her clothes were fitting more tightly, and she had a hard lump kind of near her belly button. She didn't have any regular ObGyn follow-up. And like I said, she was kind of perimenopausal. They got a CT scan at the outside hospital, and they saw this really large 15-centimeter mass in the pelvis, lower abdomen area. They weren't sure exactly where it was coming from, but thought it could be coming from her uterus or maybe somewhere in the adnexa. So she was referred to GYN oncology for further management. They got some labs of note for her. Her CA-125 level was normal, which is something that we are concerned about and want to take a look at if we're concerned that someone might have ovarian cancer. So then we ask ourselves, what imaging should we order? And something that I learned about over the past few weeks was the ACR appropriateness criteria. And this is something that you can find online, and you can actually put in your patient symptoms and kind of figure out what it is what imaging is appropriate for what's going on. So here you can see we have a postmenopausal person with acute pelvic pain, what imaging is appropriate. And she did end up getting a CT abdomen and pelvis and an ultrasound, which I'll show you right now. So this was her transvaginal ultrasound, and you can see here, this circled area is her mass, and it looks like it's kind of split in half. Some of the things I learned just through the ACR building blocks things is how to figure out what I'm looking at on ultrasound. So what the different colors mean, what something means when it's dark like this. So we can tell that this is probably a mass that has both cystic components and solid components. And that helps us determine whether we're more concerned about something being cancer or maybe something might be more benign appearing. And then she got her CT, and you can see here in the middle, this large 15 centimeter mass that should not be there. This down here is her uterus. Here you can see the mass again, and you can see that it's kind of different. You can see it's different densities, and what Dr. Hartman was talking about with the Hounsfield units, that is another way that we're able to kind of determine whether we're looking at something more solid, like up here, because it's a higher density, or something more cystic or more resembling water or something fluid filled. And then I had the chance to actually go to the OR and see the surgery for this patient. So she had a total abdominal hysterectomy. She had a bilateral salpingo oophorectomy. This here on the top is the mass. It's actually her entire ovary and fallopian tube, and then the mass is kind of coming off of that. And then when you kind of cut it up, you can see that there are parts of it that were solid and had some mucin and kind of fatty areas coming out of it, but there was also a large cystic component, and this was the fluid that came out when it was drained. And then once the mass came out, I was able to go to pathology and kind of see how they prepare the frozen section. And then a couple days later, we got the final pathology back, and these were some of the images, which you can see here. There's a lot of mucin containing cells, and the pathology actually came back as a mucinous borderline tumor of the ovary. And this was something that I was able to kind of look into more. And if you want more information on what borderline tumors are, things like that, you can kind of pause here and take a look at that. But a really good way to kind of combine like radiology findings, pathology, and how that looks in the actual application into treating a real patient.
Okay, well, we hope you enjoyed this preview of the material that's available on the Building Blocks site. And again, I encourage everyone to download those presentations and learn more about ObGyn imaging, which I think will help you with your clerkships and with future rotations and internship. Thank you.